everyone, this is Lola. I'm the Harvard Site Coordinator for New England MHTTC, and I'm just going to go over a few housekeeping items before we begin. Kesh, do you want to go in presenter mode?
Yes.
Okay, so participant microphones have been muted at entry. You'll be able to unmute them during the chat portion. Next slide, please. If you have questions during the event, please use the chat. If you have questions after the session, please email newengland@mhttcnetwork.org. At the end of this month, we will send you a certificate of completion that you can then submit to your particular board for continuing education credit. Please contact ifisher@c4innovates.com for more information after the event. This session is being recorded and it will be emailed out to all participants once available. Next slide, please. This slide includes our MHTTC acknowledgements. Next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. And with that, I will hand it over to Dr. Shirley Yan for some introductions.
Great. It's my pleasure to introduce Dr. Keshavan today. Dr. Keshavan is Stanley Cobb Professor of Psychiatry at Beth Deaconess Medical Center and the Massachusetts Mental Health Center at Harvard Medical School. He's also the academic head of the Department of Psychiatry here. Dr. Keshavan is closely involved in research in neurobiology of psychosis, especially as it pertains to first episode psychotic disorders. He has several funded research grants to better understand the neurodevelopmental basis of schizophrenia, neuroimaging, and early intervention. And he's specifically renowned for his work on cognitive remediation. His research has resulted in astounding over 900 publications to date, including 800 peer-reviewed papers, 4 books, and 100 reviews and book chapters. He's received numerous awards for his teaching and research, and as Distinguished Fellow of the American Psychiatric Association, a Fellow of the Royal College of Physicians in Canada, and a Fellow of the Royal College of Psychiatrists in the UK. Dr. Keshavan is also Editor-in-Chief of Schizophrenia Research and serves on a number of editorial boards. He's often invited to speak at national and international conferences and recently delivered a plenary address at the Schizophrenia International Research Society in Florence. And finally, in addition to his research and teaching, he maintains an active clinical practice and is also an esteemed mentor to numerous early and mid-career researchers. And I'm personally so happy that he's one of my mentors. So without further delay, Dr. Keshavan.
Thank you very much, Dr. Yan. Hope everyone can hear me clearly. Okay, so the topic that I'm going to speak about is something of clinical importance to everyone who takes care of people with serious mental illness, the issues of insight and treatment engagement, which more commonly used term is treatment adherence. I will talk a little bit about the right terminology to use these terms. So let me see here, the slide is not moving. Okay, so just a little brief intro as to insight and adherence. Insight is the ability for individuals to understand their own illness and understand the need for treatment. You know, when we do a standard mental status exam, we always look for insight as well as judgment. And it's important to make that distinction between insight and judgment. Insight is awareness about the illness, but judgment is whether the person is able to make good choices. You know, if the standard question is, if you found a stamped addressed envelope, what would you do? Things like that, a social judgment, an appropriate judgment that we take throughout our lives. And then there is the other overlapping construct, which is treatment adherence, the degree to which a person follows a treatment regime. Various terms have been used for this. The more commonly used term was compliance, which has its problems, which kind of implies a highly hierarchical system where it's the doctor who prescribes and the patient has to follow or comply with and so on, which is not exactly the optimum term for this. Adherence is an alternative term, whether a person adheres to treatment or not, without implying whether there is any kind of a authoritative relationship between a clinician and a patient or client. Even that is not an ideal term. A better term, in my view, might be treatment engagement or treatment alliance. But people could debate that, and in my slides, you may occasionally still see the term adherence. But think of it as equivalent to treatment engagement or treatment alliance. So in the disorders that I work closely with, such as psychotic disorders, schizophrenia, and serious bipolar disorders, and major depression with psychosis, loss of insight is one of the earliest signs when a person is beginning to develop psychosis. This is what Emil Kraepelin, the founding father of psychiatry, said. Understanding the disease disappears fairly rapidly as the malady progresses in an overwhelming majority of cases. And this kind of an unawareness of mental disorder is very common. Even if you include mild degrees of loss of insight, the prevalence of poor insight might be upwards of 90%. But if you define it as a moderate to severe unawareness, it's more than 50%. About 40% may have some level of insight. This is work by Xavier Amador, who is an expert in the field. I'll talk about Amador's work as we go forward as well. Insight is also multidimensional. In this talk, I'm going to talk a little bit about insight, and then I'll talk about adherence. So those are overlapping concepts, as you will hear. So there are at least three components of impaired insight. There is first a lack of awareness itself. And then there is the misattribution of the symptoms. They're aware that they're having an experience, which may be a pathological experience, but they're attributed to something that is not based in reality. That's misattribution. And then there is the unawareness of the need for treatment or appreciation of the consequences of the illness. So, for example, my grandmother speaks to me inside my head. The person doesn't even know that that may be pathological because the grandmother is not alive anymore. But still has the experience of the grandmother speaking to him or her inside her head. And that is an unawareness of the illness. By contrast to that, I know it's not my grandmother, but there is a chip inside my head that makes a sound which makes it feel like or sound like my grandmother. So she knows that there is a pathological experience, but she's attributing it to an unreal explanation. So that's called misattribution. And the third is, the person might be aware that it is a pathological experience, might correctly attribute it to the illness, but say, I know I hear voices, but that I shouldn't be hearing, but I don't need treatment. Why don't you take the treatment? That's the kind of thing that we sometimes hear from our patients. So that is the third component, which is the unawareness of the need for treatment. So these are three different dimensions of insight. And there are many people who have all three of those dimensions. They're not aware, they misattribute, as well as they don't want treatment. But there are some who have good insight from an awareness and attribution point of view, but do not believe that they need treatment and so on. So it's useful to know this distinction between the three dimensions of insight. How does one assess insight? Now, it's important to realize and be humble about this, that we mental health professionals, psychiatrists and psychologists don't know everything. Sometimes when we say somebody has schizophrenia, we are making a judgment based on a certain set of symptoms. There is no way we can prove that a person has a schizophrenic illness. It's a clinical judgment. So that can actually lead to sometimes a patient-clinician disagreement. And sometimes patients may turn out to be right, and the so-called delusions that they were experiencing might be based in reality, and so on. Over time, that we come to know, it's important to keep in mind that sometimes disagreement or a lack of understanding of the illness by the doctor of the patient itself could give a false impression as though the patient has a lack of insight. So we should always be self-reflect and be humble about it. Then there is another important distinction to make, that lack of insight may not necessarily be the same as denial. There are people who deny their illness in all of medicine. There are people who have a heart attack, but they kind of don't care about it, and they might just start doing heavy exercise or running despite having a clear-cut heart disease and so on. They're consciously aware that they have the illness, but they don't want to worry about it. They don't want to care about it. That there could be a conscious denial. Sometimes there could be an unconscious or subconscious denial as well. And that is to be distinguished from a true lack of insight. There are a number of different scales in clinical practice that assess the different dimensions of poor insight. PANS is one of them, but only assesses the acceptance of the illness label. And then there is the Insight and Treatment Attitude questionnaire by Joe McAvoy, which assesses some of these elements. And the another one by Tony David is scheduled for assessing the 3 components of insight. And then SUMD, that is the scale to assess unawareness of mental disorder, developed by Xavier Amador, is a much more comprehensive scale that assesses all different aspects of poor insight. Now, what are the correlates of poor insight? Almost 2 decades ago, we did a study of a large study of patients with first episode psychosis. And we looked at what was the strongest correlate of poor insight in our patients. And what we found was that, highly significantly, the more cognitively impaired individuals were, the more impaired their insight was. And here we were specifically referring to the unawareness component of the insight measurements. So this is an important thing to keep in mind, as we will talk about it again a little bit later. So what might be the common thing that accounts for poor cognition and also poor insight? That might be brain abnormalities. And many years ago, we looked at people with poor awareness, misawareness of their illness, and looked at how they differed from people who had good insight. As you see here on the left, many brain regions seem to have diminished gray matter when it comes to their relationship to poor insight. So we all know that cognition is determined by multiple brain circuits, and it makes sense that multiple brain regions, especially the frontal lobe regions, are associated with poor insight. By contrast to that, misattribution, which is an attribution of a pathological experience to a delusional explanation, misattribution is more likely to be related to temporal lobe pathology. So people with psychosis have both misattribution and unawareness because of these frontotemporal and generalized brain abnormalities. Now, there is another component of insight which we don't often talk about, which is called foresight. That is the ability to know what is the likely scenario a few months from now in my life, or what is out there. You know, if the typical question we ask is, what do you like to be doing in 5 years time, or 1 year time, or a few months time, and so on. People with severe mental illness, such as schizophrenia, often have diminished foresight. They often are unable to think about what is in store for them 5 years from now. And this is what leads to them just thinking about today and the next day, and not too much beyond the next few weeks or months. And that is often called future myopia. That is a lack of foresight. We measured that in a study of cognitive remediation going back a few years ago. And we looked at what were the brain correlates of impaired foresight in people with schizophrenia. What we found was that, again, frontal lobe, especially the dorsolateral prefrontal cortex, as you see here, structural impairment in the dorsolateral prefrontal cortex was associated with this kind of a future myopia. Now, can one improve insight? We talked about a number of approaches. Cognition being strongly correlated with poor insight would imply that cognitive remediation can potentially improve insight. Indeed, that was found in some studies. And a particular aspect of improving cognition that has to do with improving metacognition. Metacognition is the ability to think about our own thinking. The self-reflection. Think about how you solve problems, how you think about a symptom. That is called metacognition, thinking about thinking. And Paul Lysaker has developed a psychotherapeutic approach that trains individuals in self-reflection. And in his early data, it appears like metacognitive and insight and reflection therapy, called merit therapy, may be effective in improving insight. There are also some small literature that if you stimulate some aspects of the prefrontal cortex by non-invasive neuromodulation, that can potentially improve insight. But it's very early. There are only a couple of studies, so it is something to watch out in the literature. There is also some suggestion in the literature that certain medications like clozapine may be associated with a better improvement in insight compared to other antipsychotic medications. Again, more work is needed. So this slide basically summarizes the same key points. We talked about three components: unawareness, misattribution, and unwillingness for the need for treatment. And we saw these three examples. So if it is an unawareness of the illness, since it is strongly correlated with cognition, cognitive remediation and metacognitive therapy are the ways to go. We talked about the misattribution, like the chip inside my head, and clearly based in delusional thinking. And this is where, of course, antipsychotic medications as well as CBT could be of value. CBT, the cognitive behavioral therapy, that is specifically designed to improve psychosis. It's called CBT psychosis modules. And then there is the decline or the lack of appreciation of the need for treatment. I know I hear voices, but I don't need treatment. This is where approaches such as motivational interviewing will be of value, and we'll talk a little bit more about that as we go forward. Now, I'll talk to you about insight, and let me move on to the next important topic, which is adherence. They're not the same, but they do overlap. There are many individuals with good insight, but poor adherence. there are a number of individuals who are highly adherent to or engaging in treatment but have no insight. So there is a population, of course, that have poor insight and poor adherence both. So as I said before, poor insight is a predictor of treatment adherence. But there is another major predictor, which is the nature of the relationship between the clinician and the patient. A relationship with someone who listens without judgment, respects the patient's or client's point of view, and believes that one would benefit from treatment. That is a strong predictor of treatment adherence. And of course, there is this, a cartoon. How many psychiatrists does it take to change a bulb? Just one, but the bulb will have to be ready to change. So basically, this underlines the principle that I just talked about, which is the fact that people make their choices and their decisions based on what they find as advantageous for them. If they perceive benefits from the treatment, they're more likely to follow up with treatment. If they perceive more disadvantages with a given intervention, they're less likely to follow up with the treatment. So all those factors that increase on the left side of this slide, all of those that increase the patient perception of treatment-related advantages are more likely to follow up with treatment. Treatments that are effective, treatments that are safe, simple to take, inexpensive, good therapeutic relationship, good level of supervision, the presence of insight, family support, intelligence, acceptance of the illness, perception of severity, as well as perception of susceptibility to relapse, for example. These are all predictors of good treatment adherence. On the other hand, all the opposite ones, ineffective treatments, side effects, too complex a regime, too expensive a treatment, poor therapeutic alliance, cultural and family barriers, poor insight, stigma, asymptomatic status. Many patients, once their symptoms get better, they don't want to accept treatment anymore. And that's the kind of antibiotic model. I had the fever and the antibiotic took away the fever. I don't need the treatment anymore. But psychiatric illnesses don't work that way. But still, many patients, once they're feeling better, they want to get off the medication. Psychosis itself and the delusions that go with them would diminish treatment adherence, sometimes grandiosity, and cognitive impairment. We'll see some case examples as we go forward. So if the patient perception of disadvantages are more, that leads to treatment non-adherence. If the patient perception of benefits are more, that leads to treatment adherence. So this is called the disease health belief model. It's widely used in understanding not only treatment compliance in psychiatry, but also substance abuse compliance and so forth, and also compliance in or adherence to medical treatments. Adherence is a continuum of severity. There are a small number of people who are highly adherent to treatment, or 100%, and there are a small number who are completely non-adherent or non-compliant. But the majority of people fall in between. And the non-adherence matters because it has been found, for example, by Jeff Lieberman in a study many years ago, that if you look at people after the first psychotic episode, the amount of time it takes to stabilize someone with psychosis in the first psychotic episode may be about, say, a couple of months. But it almost doubles after the second episode. And after the third episode, it takes even longer to stabilize someone. So That is an important reason why it is important to prevent non-adherence. And among the various medical and psychiatric disorders, non-adherence is highly common. But among most medical and psychiatric disorders, schizophrenia tends to be at the top in terms of how frequent non-compliance is, only after weight reduction. Then there are many other medical conditions and psychiatric conditions that fall below. And which is the condition where the treatment adherence might be the highest. And not surprisingly, it tends to be OCD, which is not in the slides. And in schizophrenia, which is the population that I closely work with, as I said, it is one of the most highly likely to cause non-adherence. A study was done by Jeff Lieberman called the KT study. Goes back about 15 years or almost 20 years. And KT study found that after the first introduction of an antipsychotic medication, almost 74% discontinued the medication by 18 months. So it really is quite humbling. The majority of people do drop off of treatment. Now, how does one estimate the presence or absence of treatment compliance or treatment adherence? There are several ways in which one could do that. Of course, you can ask the patients, you can ask clinicians, and you can also do some other things. If you ask clinicians, this was an actual study in which a clinician was asked, how many patients do you think are actually taking the medication? And the reports were more like 80%. But when the patients were asked, it came down to closer to 60%. And then they did what is called the MEMS cap, medication monitoring system cap. So basically, these are pill bottles that have a cap, and each time the cap is opened, it registers into a chip in the cap. And every time that they come to see you, you can run the chip from the cap through a computer device, and it gives you how many times they opened the pill boxes. And it gives you an idea as to how they were following with treatment. And with that, the proportion came down to like 40%. And the fourth approach is actually each time the clinician counts the number of pills left. They have to bring the pill bottle back to the clinic. And maybe a caregiver will keep an eye on the pill count on a regular basis. And that brought it down to closer to 20%. So there are multiple approaches to assessing non-adherence. The more comprehensively one assesses, the more likely to find non-adherence. There are a number of clinical scenarios, and non-adherence is not one thing. There are multiple ways in which non-adherence can present itself, and we'll take each of these through some case examples and see what's the best approach to address those. First is those that believe that they don't need medications. Then there are those that refuse medications. Then there are those in whom the medications are not working, and which is why they are not taking the medicines. Then there are those who don't take the medications because of side effects. And then there are those who don't show up for their first appointment, and then it goes downhill. And then there are those who frequently miss or forget to take the medications. So let's take each of these by turn. So here is a 21-year-old college freshman, and she was admitted for refusing to eat, declining grades, poor self-care, wandering the streets, believes that she's not ill, but admits to hearing whispering sounds cluttering her thoughts. So this is where she was when she first saw in this case, I was the clinician. And she was actually not in any kind of a dangerous situation. She had not lost any weight. So she came in involuntarily, but then she was let go by the court and she became an outpatient, but still was not taking the medication. So this is the situation. So what would be once the approach to take in someone like this to get her to accept some treatment? The first couple of sessions, I did not make any progress at all. And then as I began to get to know her, it turned out that she was willing to talk about all the reasons why she dropped out of her college from an Ivy college. So in talking to her, I asked her what was she studying, and she said she was studying electrical engineering. And I asked her, what what are you learning in classes when you dropped out? She said she was studying about how the radios work and how the information processing systems work and so on. And so then we got into a discussion of signal and noise. And so I asked her, what happens if your radio is not getting the right signal? And she said, obviously you hear a lot of noise and you may hear static and so on. So I asked her, look, is it possible for you to think about your brain like being like a information processing system, like a radio? And if it is not processing information in the classes, so you're not concentrating, and that's why you had to drop out of school. And then it was causing this kind of static in your head. And that is why you were hearing these whispering sounds in your mind, cluttering your thoughts. Would you consider that as a possibility? She thought about it and said, that does make some sense. What do you think could be done about it? I explained to her, I went to the drawing board and explained to her that the information processing system in the brain is done by a particular brain neurotransmitter system called dopamine. And if the dopamine is not functioning right in the prefrontal cortex, that makes the signal to go down when you're processing information. And then another part of the brain, the dopamine might overact, and that might lead to this static, the voices. And there is this medicine called Abilify, which turns down the lower brain dopamine, but enhances the higher brain dopamine. Would you be willing to consider it? So she said, okay, I'll give it a try. And then she took it and she started feeling better. So that's an example I gave you, which illustrates the key point that Xavier Amador made in a very well-known book called I Am Not Sick, I Don't Need Meds. And his 4 key principles that he talks about are summarized in this LEAP approach. L stands for listen, and E for empathize, and find a point of agreement, and then develop a partnership. So what I did with this young lady was to get her perspective as to what is it that she's agreeing with me. She agreed that her mind was cluttered. No argument there. She agreed that she was not able to stay in her classes. So with that as the starting point, we developed together a model, an illness model that she could understand and I could present to her, in which case we developed a partnership in that sense. So that approach is the LEAP approach for people who have poor insight. Of course, not everybody can this work. If someone who is dangerously ill will have to take other approaches, but this could work in a number of people. So these are the key principles of the LEAP principles. Listening reflectively to delusions, not challenging the delusions, but you don't have to necessarily agree with the delusions, but you can, develop an alternative viewpoint and so on. Empathizing and normalizing the experience to the extent possible, and developing a point of agreement by not only listening, but also summarizing and reviewing points of agreement, and then reflecting back and highlighting the potential perceived benefits, and also bring out both the disadvantages as well as the benefits, and let the patient weigh them together. So ultimately, as I pointed out in the slide that talked about the health belief model, ultimately they are going to do what they think is advantageous to them. So if there is ambivalence, present to them both the pluses and minuses of treatment and let them understand and figure out what works better. Now, there are patients who, for example, relapse repeatedly, and they don't, each relapse is because they stop their treatment. And then you sit down with them and talk to them about all the perceived downsides of relapsing, having to get into the hospital, having to, stop working, having to lose your apartment. So present all of those together, along with the perceived disadvantages of the medicines, and also presenting to them alternative ways of minimizing the disadvantages. So that's the way to address and use the LEAP approach. And also, when giving opinions about the diagnosis or about the illness, or about, say, symptoms that we believe are delusions, we don't necessarily have to tell them something that they disagree with right away. You can buy time. You could delay giving opinions. If it's all right with you, I'd like to first hear more about your symptoms, or for example, or I'd like to keep listening to you because there's a lot I didn't know. Can I tell you later what I think? So buy some time, so you're building the relationship. And then there is the approach of I'll tell you what I think after I learn more from you about what you think. So, and also when you're finally having to give an opinion about the nature of the illness or nature of the symptoms, it's good to always use humility. I want to apologize because my views might feel disappointing to you. I could be wrong. I don't know everything, but this is what is the best of my understanding. Acknowledge fallibility. Also, find out points of agreement. You may not necessarily agree about some things that I say, but then let's agree. You and I both agree that you have a problem with sleep. So let's focus on that. Or you have a problem with being able to concentrate, and so on. So let's think of another person who is more severely ill, admitted for, he was climbing a high-rise building and he thought that he was Spider-Man and that he could patrol the downtown at night so that he could save lives. He believes he's not ill and he is refusing medications. What does one do in these kind of situations? Of course, the same principles that I talked about listening to the patient's concerns and goals of treatment, trying to explain the nature of the problem to them, identify and address barriers for treatment adherence, get some allies from the family. They may not listen to you, but they may be willing to listen to a friend or to a peer support person or to a family member. So marshal all the support one can get. And also get a second opinion. So sometimes none of these things work and there may be no other choice other than to get a court-ordered treatment, but a court-assisted treatment. But that's only if all other options have been tried and failed. Motivational interviewing principles. So we talked about the approach to interviewing, which involves beginning with open-ended questions, affirming the patient's thoughts and acknowledging and reflecting them, and also exploring their own ambivalence about treatment, and then summarizing them and present to them about the pluses and minuses of treatment. This approach, the acronym for that is ORS, asking open questions, reflecting what you hear, and developing a partnership by exploring points of ambivalence. So those are the principles under motivational interviewing. This principle has been captured in a treatment approach called compliance therapy, which has been found to be superior to treatment as usual. And of course, compliance therapy doesn't always work, because in order for compliance therapy to happen, patients have to show up, and often they don't. So that's a problem. Now, this young man was seen in the emergency room for recent paranoia and auditory hallucinations. He is prescribed Risperdal, discharged. He is seen again. He's not seen again in the clinic, but this clinic, in the psychiatric clinic, but presented it back to the emergency room the following day, believing that he has meningitis. So what was happening was that his head was going back, his eyeballs were rolling up. So he thought he had a neck stiffness. So he went to the emergency room. So what might have happened here? Clearly, he was having a dystonic reaction to Risperdal and had not been explained that this could happen. So the best way to prevent this is to proactively explain the patients as to what is likely to happen, and also what to do if they appear. So in the absence of clear understanding, he went straight to the emergency room, but he could have called the clinician and explained. And of course, if there are side effects, switching to a different medicine or lowering the dose are considered as a side effect medication. So, like say benztropine would have taken away his dystonic reaction. So many times, treatment non-adherence and treatment refusal is simply because these medicines are not benign. They have side effects. They sometimes can be very uncomfortable. Especially akathisia, the restlessness that they experience, which is one of the strongest factors behind non-compliance with antipsychotic medications. But thankfully, the more recent atypical antipsychotic drugs have less of that problem, but they still do sometimes. And of course, economic side effects. Often treatment non-adherence is because they just can't afford it, or they have lost their prescription, or it's too expensive to go back and get another doctor appointment. This young man was an unemployed lawyer, treated with olanzapine up to 40 milligrams per day for intractable beliefs that his family has been replaced by replicas. They're cloned. So the resident is puzzled as to why the patient has not put on any weight. So 40 milligrams a day is a pretty big dose of olanzapine. So what might be going on? So clearly, he was obviously not taking the medication. Why was he not taking it? Because his delusions, which are like the Capgras delusions, which are about delusions of imposters, doesn't easily respond to antipsychotic medications like olanzapine. So he was not responding. So this is an example of a treatment resistance or lack of efficacy. So what does one do with treatment resistance or lack of efficacy? Assess treatment adherence, re-evaluate the diagnosis, whether you have missed something, whether it might be a medical illness that has been missed or another psychiatric disorder that has been missed, maybe like depression or substance abuse. Also check whether the dose is right, whether the medicine has been given for enough of a length of time, and consider augmenting with another medication. Consider alternative medication. Sometimes clozapine could work when other medicines don't work, and so on. So this young man is discharged from the inpatient service on a Friday. On Monday, the nurses note that he forgot to take his follow-up instructions. So he missed his appointment, but was not seen till a year later when he comes with a severe psychosis relapse. So what might have happened here? The discharge planning did not happen right. So ideally, one would want to not only make sure that the patient takes the instructions, but also follow up after discharge to see how they did. And so the key point is enhancing therapeutic continuity. And if the patient is not accessible by phone, consider sending a letter, improve social supports and services, and evaluate barriers to treatment. And quite often, access to healthcare itself is a major barrier, and that could cause treatment non-adherence. This 26-year-old woman, she has 3 young children. These are all patients from my practice where I have, kind of slightly or somewhat changed their story in order to hide any identity. So this young lady, she has 3 young children. She was prescribed Geodon, that is ziprasidone 40 milligram twice a day, clozapine 50 milligrams twice a day, lithium 600 milligrams per day, valproate, Depakote 500 in the morning and 750 at night, and cogentin, benztropine 1 milligram twice a day. One day, the police are called in the middle of the day since she didn't answer the door and the children are crying inside. So what might have happened? What really happened was she is on multiple medications. So what is the one thing that is common to all of these medications? Clozapine, cogentin, valproate, lithium, and the antipsychotic, ziprasidone. They all have anticholinergic effects. Now, one of the best ways to wipe out one's memory is to take a strong anticholinergic. And she had 4 of those. So clearly, she got up in the morning, took her medicines, fell asleep, and then got up again, didn't remember that she had already taken the medicines, took the whole medicines again, and fell asleep, of course. And so here, the cause of the non-adherence was actually hyperadherence because of poor memory and cognitive impairment. So one needs to consider, keep track of the prescription amounts and coordinate information with pharmacy, identify the barriers for the medications. Like in this case, it was a complex regime, and there was no way for her to remember to take the medicines at the right time and so on. Considering pill boxes, cues for the patient, and having a family member or another care provider to support. All of those would help in a situation like this. And also assessing medication adherence regularly by patient reports by caregivers, pill counts, plasma levels, all of those would be helpful. So, in complex cases with multiple problems, it's good to have another person manage. It could be a group home supervisor, or it could be a case manager, it could be a family member. Having another person keeping an eye on the medicines, using reminders by wristwatches, and pill boxes, and calls by the pharmacy, and also these electronic caps, which I talked to you earlier, MEMS caps, appointment reminders, daily checklists to monitor symptoms and side effects. And so all of these could be helpful in improving adherence. We talked about this medication event monitoring system. And then there are pharmacological approaches to improve adherence. So that's a separate and detailed talk in and of itself, but it's important to keep in mind that depot injections are really an important, valuable tool to address problems of non-adherence. The long-acting injectables are available both for conventionals like haloperidol and fluphenazine, but are also available for more recent atypicals like risperidone, olanzapine, paliperidone, which comes as Sustenna, or Invega Trinza. And then there is aripiprazole, comes as Maintainer once a month, and Laroxil or Aristada, which is once in 2 months. And also there is more recently a FDA-approved approach where there is a pill that comes with a little inbuilt chip, which can check and tell with a smartphone app, can let people know that medicine has been taken or not taken and so on. It's not really that widely used yet, but it is one option. And plasma level monitoring is useful as well. It is available for some of the medications like clozapine and risperidone, but not all of them. And here are some more details about the different long-acting injectables. And there are some which have some advantages than the others. For example, paliperidone, Sustenna, can be given without a need for a parallel oral supplementation. So that's an advantage. And the same thing is also true for olanzapine, but the olanzapine has its own problems of causing weight gain, metabolic syndrome, post-injection delirium, and so on. So again, I went into these details. I'm happy to make these slides available to people. Again, as I said, cost also is a factor. Some of the conventionals like haloperidol are much less expensive, but the more recent atypicals can be somewhat more expensive. So my take-home points are: insight is multidimensional. Insight is strongly correlated with adherence. Impaired insight may be related to altered brain structure and function. I did not mention that there is a neurological condition called anosognosia, where people who have a, let's say, a stroke-like lesion in the right hemisphere, which leads to left-sided paralysis, they completely deny their stroke. And even that left side limbs exist. And that is called anosognosia. Xavier Amador has argued that the lack of insight in schizophrenia is like an anosognosia. It's a neurological condition. So which is why treating the underlying neurological dysfunction in schizophrenia with cognitive remediation could be helpful. One aspect of insight, foresight, may be related to poor judgment as well as poor adherence. And some interventions are experimental: metacognitive therapy, cognitive remediation, neuromodulation, and clozapine may improve insight, but more studies are needed. And there are multiple reasons why people fail to accept or follow up with treatment. Those who refuse treatment may benefit from, of course, improving treatment alliance, the LEAP approach, and where there is treatment, lack of treatment efficacy, considering alternatives like clozapine, appropriately identifying and treating side effects, improving hospital to clinic continuity, improving patient access to treatment, memory aids, and cognitive remediation. All of those could be of value. I think I'll stop there to see if there may be time for 1 or 2 questions. Thank you.
Thank you so much, Dr. Keshavan. That was an excellent presentation. I do think that there's one question. Ken Farbstein, would you like to unmute yourself and say your question?
Sure. Dr. Keshavan, thanks very much for this talk. In thinking of family engagement and how that affects engagement, adherence, and so on, is it usually the mother who's most effective? Is it father, brother, sister?
Yeah, so in my practice, I've seen that mothers are more often taking that role compared to fathers, but there are also sometimes fathers who, I think it's always a good idea to have a family meeting at the very beginning and see how in any given family these roles are being apportioned. And sometimes, I've had a patient recently, the mother had to go away to another country. And because we had this agreement that the father would step in and take over, the father really did a marvelous job of taking over that for a couple of months' time. Yeah.
Any other?
And Dr. Condemarin.
Yes. Oh, hi.
Yeah. Oh, hi, Kesh. Thank you so much for a wonderful conference as usual. I was listening to you, and just today, in between, I got a call. One, for instance, in my general who want to be the charge and develop a severe akathisia after getting Aristata, And we discussed it with the resident a couple of weeks ago, the big issue about insight, especially in mass mental, we having people with a very poor insight. Many of them in guardianship because not taking the medications. But I think you mentioned something very good in your slides is the relationship. We have good cases that people who have very, very poor insight, no insight for years, but they are the one who take the medication.
Right.
Or people who make it their routine, especially the clozapine people, who need to come and they develop this, and after the COVID that they couldn't come, they lost the track. And another good point that you said is like a buy time, little bit. We jump it too quickly in prescribing, and we believe like giving too many meds, we want to solve the problem. Thank you so much for the talk.
No, thank you. You're absolutely right. There are many people who accept treatment just because the good doctor told me to do so. And we should maintain that to the extent we can.
Well, thank you so much, everyone, for attending. And thank you especially to Dr. Keshavan. We're at time. Thanks again for an excellent presentation.
Thank you.
Thank you, Kesh.